Hello everyone, so today Janeth and I are going to delve into the world of B-cell acute lymphoblastic leukemia, or just also known as B-ALL. B-ALL is a type of blood cancer that originates from immature B lymphocytes. It has an incidence rate of approximately 5 cases per 100,000 people annually, and it accounts for about 80% of leukemia cases diagnosed in children. Recognizing the symptoms in B-cell acute lymphoblastic leukemia, disruptions in normal regulatory mechanisms lead to uncontrolled proliferation of immature B cells. This abnormal proliferation is driven by various factors, including dysregulation of key genes such as PAX5, which normally controls B cell development from proto-mature B cells. Additionally, the inhibition of autophagy, a cellular process that maintains homeostasis and prevents abnormal cell growth, further contributes to uncontrolled proliferation by halting cell cycle progression at G2M phase. As a result of this unchecked proliferation, immature B cells infiltrate tissues and organs throughout the body. This infiltration leads to characteristic clinical manifestations such as lymphadenopathy, which is enlarged lymph nodes shown at the top picture, and hepatosplenomegaly, enlarged spleen and liver shown at the bottom picture. These symptoms are important clinical indicators of B-ALL and highlight the systemic impact of the disease on the body.
B-ALL and the immune system. So on the right we have two images. The top one is the normal bone marrow and the bottom is the B-ALL bone marrow. You can see that the leukemic B cells are gradually proliferating and they commandeer the bone marrow microenvironment, leading to bone marrow failure. And this is going to cause the loss of immunosurveillance and it lets cancer progress. So the B cells are also going to infiltrate the central nervous system. And one of the therapies that is commonly used for this is chemotherapy, but it targets the leukemic B cells and it also targets the normal immune cells. So this could lead to a patient being more susceptible to infections since you lack the normal immune cells. Mononuclear cells. So these are cells in the blood that specialize in immune response. You have lymphocytes, which include B cells, T cells, and natural killer cells. You have monocytes, which include macrophages and dendritic cells. And you have hematopoietic stem cells, which have the capability of self-renewal, and they differentiate into erythroid, myeloid, and lymphoid progenitor cells. So the bone marrow mononuclear cells, they are isolated from bone marrow aspirations, and the peripheral blood mononuclear cells are isolated from whole blood. B-ALL innate immune response. The natural killer cell dysfunction is going to contribute to the development and progression of B-ALL, and it creates an immunosuppressive environment in the peripheral blood and the bone marrow, which hinder the function of the natural killer cells. On the left, you have the bone marrow graph. You have the healthy bone marrow mononuclear cells in the blue, and you have the BNT-all bone marrow mononuclear cells in red and green. You can see that most of the BNT-all bone marrow mononuclear cells are ranging from the 0 to 20%, but you do have a few B-ALL cells ranging from the 40 to 60%. However, on the right, you see the peripheral blood mononuclear cells. Most of the healthy cells are ranging from the 80 to 100%, while the B and the T-all peripheral blood mononuclear cells are ranging from the 0 to 20%. So this just shows the significantly lower natural killer cells count in the B and the T-all in comparison to the healthy cells. B-ALL adaptive immune response. T regulatory and T responsive cells aid in understanding the dysregulation in B-ALL, which may lead to potential target for therapeutic intervention and monitoring. The Tregs, listed as CD4 positive, CD25 positive, suppress immune response, maintaining homeostasis and self-antigen tolerance. T responder cells listed as CD4 positive, CD25 negative are the effector T cells. In the graph, the gray displays the control group, so you have a ratio of 1 to 0, 1 being the T responder cells and 0 being the T regulatory cells. In the black, you have the experimental data with the ratio of 5 to 1, 5 being the T responder cells and 1 being the T regulatory cells. So you can see that the T regulatory cells suppress the T responder cells' ability to respond to B all cells.
Research for new therapies aimed at reducing side effects, improving outcomes, and decreasing relapse stages of B-cell acute lymphoblastic leukemia is actively ongoing. Immunotherapies represent a promising frontier in this endeavor, with two notable approaches being monoclonal antibodies and CAR T-cell therapy. By harnessing the power of the immune system, immunotherapies offer innovative strategies for treating B-ALL, while potentially mitigating the toxicities associated with traditional chemotherapy regimens. Ongoing research aims to further optimize these therapies and expand their application to improve outcomes for patients with B-ALL.
Monoclonal antibodies. These are synthetic antibodies that can target specific antigens in B-all cells to enhance natural killer cell detection. There are two types: antibody-dependent cellular cytotoxicity and complement-dependent cytotoxicity. For the process, you are first going to present the antigen to the mouse, and the mouse is going to make antibodies against that antigen. Then you are going to fuse myeloma cells, which are cancerous plasma cells, to the B cells to make hyperdoma cells. You are then going to screen for antibody production using methods such as the ELSA method. So if you are screening to check if an antibody was produced, which ELSA method would be used? It would be the indirect method. So you're going to have the antigen coat, the antibody from the hyperdoma, and then the antibody with fluorescence for detection. Once an antibody is confirmed, the hyperdomas are cloned, and the antibodies are isolated for cultivation.
CAR T-cell therapy involves modifying a patient's own T-cells to express chimeric antigen receptors that recognize and bind to antigens present on B-all cells. Once engaged, CAR T-cells unleash a potent immune response against the cancer, leading to tumor destruction. This personalized treatment approach has shown remarkable efficacy in some patients, including those with refractory or relapsed B-all. A study was performed where they took 15 cancer patients and treated them with anti-CD19 CAR T-cells. The graph shows blood levels of CAR-positive lymphocytes expressing CD57 at the time of the infusion and after 7 days at peak. Can anybody think of any problems that may arise with CAR T-cell therapy? In B-cell acute lymphoblastic leukemia, abnormal proliferation of immature B-cells in the bone marrow disrupts normal immune function. Understanding the roles of innate and adaptive immunity is crucial for developing effective treatments. Innate immunity involves natural killer cells which recognize and eliminate virus-infected or malignant cells. However, infiltration of immature B cells hinders NK function, compromising this innate defense mechanism. Adaptive immunity involves regulatory T cells, Tregs, which secrete inhibitory cytokines that dampen macrophage phagocytosis, impairing the body's ability to clear leukemic cells. Therapeutically, monoclonal antibodies can be genetically engineered to enhance NK cell function, bolstering innate immunity against B-all. Additionally, CAR T-cell therapy involves modifying T cells to target and eliminate leukemic cells, leveraging adaptive immunity for targeted treatment. By targeting both innate and adaptive immune responses, novel therapies aim to improve outcomes for B-all patients by enhancing immune surveillance and clearance of leukemic cells. As stated before, understanding these mechanisms is crucial for developing therapeutic strategies and improving patient outcomes. Thank you so much for your guys' time, and I hope you guys have a good rest of your day. Please let us know if you have any questions.